So my name is Dr. Douglas Bradley. I'm a professor of medicine at the University of Toronto. I'm the former director of the Division of Respirology for the University of Toronto. I also run the sleep medicine programs at the University Health Network in Toronto. Well, prior to the trial that I just presented, there was evidence from smaller trials, many of which were done in my laboratory, that treating both obstructive and central sleep apnea improved cardiovascular function by increasing ejection fraction, reducing sympathetic nervous system activity, and also there's evidence that it improved exercise tolerance on the 6-minute walking test. So there was a number of physiological factors that improved that would suggest that it might improve mortality and hospitalizations as well. The study device is called Adaptive Servo Ventilation. Basically, it's like a pacemaker. So if you're stop breathing, if you stop breathing, you have a central apnea, the machine will ventilate you, okay? If you don't stop breathing, it just provides a low background pressure but doesn't ventilate you. If you have obstructive sleep apnea, it increases the pressure, the background pressure, but it doesn't ventilate you, but it just raises the pressure enough to keep the airway open. So it treats both central and obstructive sleep apnea. The device we used is made by Philips Respironics, and it's triggered by what's called peak airflow. So that means that it's aiming, if the peak airflow drops below a certain point, it will start to ventilate you or to treat your obstructive sleep apnea, depending upon which type of apnea you have. It's different than the device used in the SERVE trial. The SERVE trial used a device that was triggered by minute ventilation. And it was a more aggressive device with higher background pressures. And in the SERVE HF trial, which was published in 2015, they found that that ventilator actually caused an increase in mortality, and therefore it's not used for that indication anymore. So that's the device that we use, and it's different from the other one. The study population was men and women, adults, with low ejection fractions, below 45%, with a history of heart failure who were on stable medication and were stable clinically. So basically that's the population we aimed for, yeah. Key findings were that in 731 patients that we analyzed, the group randomized to the device had a marked reduction in their apnea-hypopnea index, so it completely got rid of their sleep apnea over the entire 5-year course of the trial, and it didn't matter whether they had obstructive or central. It treated both. However, there was no significant difference in the primary endpoint, which was the combination of cardiovascular hospitalizations, death from any cause, atrial fibrillation, onsite atrial fibrillation, and ICD discharges. There was no significant difference between the two groups and it didn't matter whether they had obstructive or central. It didn't make any difference. On the other hand, it didn't cause any harm, so it's unlike SERVE, in which patients actually had a higher mortality. In our trial, they didn't. If we looked at mortality alone, there was no significant difference, again, between the two groups, either obstructive or central or the whole group. On the other hand, in the central group, we had fewer patients than we had anticipated, because in 2015, when the SERVE trial results were published, regulatory authorities in Germany and France disallowed enrollment of patients with central sleep apnea, despite the fact our Data and Safety Monitoring Committee had seen no safety signal at all. So they overruled our Data and Safety Monitoring Committee. So there's a major ethical problem here. And as a result, instead of getting 430 patients with central apnea, we only got 198. In that group, there was a trend towards a lower mortality. The hazard ratio was 0.78, which means a 22% reduction in mortality rate, but the p-value was 0.34, so it wasn't significant. On the other hand, that difference between the two groups is a difference we predicted when we created the sample size. So the conclusion then would be that there's no indication to treat, the other point was the patients with obstructive apnea had to be non-sleepy, because if they were sleepy, they would have an indication to be treated. So in non-sleepy patients with OSA, there's no indication for them to be treated if they have heart failure, because we don't have any indication that it improves their outcomes. In the central apneics, there's a trend towards improvement, but not significant. So there's no indication, therefore, to treat them either. However, the quality of life data have yet to come out, and if the quality of life data show an improvement, and we've shown that the device is safe, then there may be an indication to treat people who have bad heart failure that's relatively refractory to drug and device therapy. I don't, at the moment, with the fundings we have, I don't think it will have a big impact, except that cardiologists will be more reluctant to send patients for sleep studies because we don't have any evidence that treating the non-symptomatic patients with obstructive sleep apnea does any good. Similarly, with the central apnea, again, depending upon what the quality of life data show, I don't think it's going to have a major impact there either. The major impact is that we do show that there's no harm, but we also show that there's no statistically significant difference in the major outcomes. Well, in the central apneics with the device we used, again, there's a signal there, it's just not significant. The problem is funding these trials, right? So these trials are funded, in this case, by Philips Respironics and by our Canadian Institutes of Health Research by a peer-reviewed grant. But we don't have the kind of money that pharmaceutical firms have. And so it's very difficult for us to do studies with thousands of patients because we just don't have the money. If I had the money, I would have extended the trial in the central apneics because we still have equipoise there. And if we got 400 or 500 patients, we might see a difference. So if somebody wants to do it, I'm near retirement, so it's not going to be me. But there is a signal there, and if somebody wants to follow that up, they should do that. But I suspect they're going to have a hard time getting funding for it.